Are we in a healthcare revolution? All the ramifications of artificial intelligence, whether it's orders of magnitude improvement in clinical research or actual delivery of care, or is it still somewhat out there in the periphery and basically a big maybe?
It's an exciting time. There's some fundamentals of the US healthcare system that are profoundly important. And if you have people that don't have access to healthcare, to Medicaid, that can't see their provider, like all of that data is not going to be put to use. And it doesn't fundamentally change the fact that we pay way more than other countries for similar services. The fundamentals of the US healthcare system haven't necessarily changed by virtue of new technological improvements.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
All right, welcome to the latest Scale Community Analyzing Healthcare podcast. That's my alarm telling me that we should get started. So I'm joined today by Doug Jacobs, who's the former Chief Transformation Officer at Medicare, former Chief Medical Director at Pennsylvania Department of Health, practicing primary care doctor. Are you still practicing?
I am, yeah. I see patients once a week.
So you're keeping it real,
I
as they say in this industry. I, on the other hand, am just completely out there in the stratosphere, dealing with concepts, but not actually getting my hands dirty with actual patients. I have the misfortune of not being talented enough to juggle both balls. And so I have to be honest, I always have a little bit of envy when I speak to a clinician who's both a clinician, but also transforming the industry. It seems like such a rich way to live life. Honored to have you. Long-winded way of saying honored to have you on our podcast.
It's really a pleasure to be here. Thanks for having me on. Excited for the conversation today.
Good. We have a lot to cover. So we're going to jump straight in. Your time at Medicare was, when did you leave?
Just a month ago, about.
So this was all very recent. And how many years were you there for?
Almost 4 total.
Almost 4.
Yeah.
Okay. So Medicare just came out with a new fee schedule, brand new. What are your initial impressions? What are your thoughts? What's happening? What was good about it? And where do you have reservations?
There's a lot in this fee schedule that I think are really important and notable. First, it's the first fee schedule that has come out with the new administration. And so the calendar year rules, so the physician fee schedule, the outpatient prospective payment system, this administration had time to put their imprint on it, given when the administration started. And so I think it's really important to look at this fee schedule and to see what's included as directional indicators as well. And so there's a lot in here that we could go into. The rule is 1,800 pages.
But I'm laughing because the one thing that I heard anecdotally was this big cheer from across the country from cardiovascular surgeons and cardiologists in response to elevated rates for outpatient ASC surgery centers. And I know the vascular space historically, and I think the vascular space also saw an uplift. Historically, they saw a significant decrease in reimbursement rates. So that's the one thing that I know happened. The cardio groups, they're thrilled, but I'm sure there's a lot more to report than that. So curious to hear your feedback.
Yeah, it's every specialty society comes out with their wins and their losses, what they like, what they don't like. I think the one of the headlines every year is the conversion factor, and so that is basically the amount that payment is either going up or down. So payment is going up by a little bit more than 3%, and it goes up even more if you're in an advanced APM, alternative payment model. And so that was in part due to the recent legislation. Underneath that, though, there's some really important policies. The first is the efficiency adjustment. And so for the longest time, when new procedures would come out, new diagnostic tests would come out, CMS typically relied on the Relative Value Scale Update Committee, or RUC, to give them recommendations on like how to value different services. And it takes a long time in between when those initial values come out and when services get revalued. So over time, when there's improvements in technology, improvements in workflow, things get more efficient. Because those times are decreasing, a proceduralist, someone running diagnostic tests can bill more and more and more in an individual day in the fee schedule. So what the efficiency adjustment does is an across-the-board cut on diagnostic tests, radiology, and procedures, and that actually bumps up the conversion factor for everybody. And so it has a somewhat redistributive effect. And basically, for the longest time, cognitive services, an office visit, for example, because of the budget neutral nature of the physician fee schedule, they've been undervalued as these other services have been over. And so it's helping to kind of readjust that. And it would be every 3-year process of taking this efficiency adjustment. So that's
let's just take a step back and just ask some basic fundamental questions about pricing in Medicare.
Yeah.
Because I find the whole thing is a little odd to me. And let me just try to frame it as an economist. Not that I'm a great economist, but I'll do my best. So pricing typically is driven by a few inputs, not just one. And it always seems to me that Medicare is more focused on one or two and almost disinterested in 3 or 4 that the rest of us have to live with and respect. And so you end up with something a little bit perverse. And I wonder if that gap between Medicare pricing and everyone else's pricing is widening as a result. So what's driving Medicare pricing? Budget neutral, right? That's not driving United's pricing or Cigna's pricing, right? Or Aetna. It's not, first and foremost, budget neutral. And then with that, it's almost, there's almost a perverse incentive to assign value with a pre-existing bias. The other considerations to value demand. So is there too much focus on an esoteric attempt at assigning value to a procedure or a consultation? I'm speaking of the RVU structure. Time units times dollar value equals therefore the price. Where are we in terms of the gap between Medicare pricing and everyone else's pricing? Because I think it's widened materially over the past couple of decades. And is it sustainable? I mean, at the end of the day, maybe Medicare comes clean and says, look, we have a cap on spending. And so the pricing is mostly driven by that. We do our best, leave us alone. So it's a convoluted question from an outsider looking in, but it just seems to, what about the market? What about market signals? What about patients saying, we really want more cardiovascular treatments. Make sure we have more cardiovascular surgeons. And so I sort of embed in that also this constant strain of supply. Like we're always short on clinicians. Is the market efficient? And to what extent does Medicare pricing help or hurt in that respect?
Well, it's a complicated question. And
I'm trying to unpack it in my own head as I ask it. And
absolutely.
I clearly don't have the answer here, but I just wonder, what are we doing with all these time value units? And is there another better way?
So it's a great question. Medicare is constrained in a few areas. It has to set prices based on the resources and time that go into the service.
That's supply driven. A manufacturer costs plus.
Right.
That's one way of establishing prices. Okay, but it's not the only way.
No, it's not. And per your point on demand and demand for services, by statute, Medicare doesn't adjust valuation based on demand. And
that's the broken market signal.
And
right?
so,
because you want prices to go up to meet ever-growing demand. That's basic economics. Because A, it holds back too much demand, right? It sends a signal that there's a constraint on resources. And B, it invites more resources to jump in. I'll stop there.
So per your point on demand, there are some good examples of that. People really value strong, effective, advanced primary care. People also really value access to behavioral health treatment. We are seeing increasingly, because of Medicare undervaluing those types of services, those practitioners are not accepting Medicare patients in the same rates that they used to.
And there are not enough practitioners.
And there's not enough practice.
I have a Jewish wife. Why is she not instructing all 3 of our Jewish children to become doctors? She should be. There's plenty of demand, but she's not doing it. I blame Medicare.
I mean, as a physician myself, it does take a long time to go through the process. So if you're not committed to it, make
But
sure.
this is what Jewish mothers used to do. Go
I
be a
know.
doctor. What
Jewish,
happened to that?
Yeah, my Jewish mother was thrilled when I went to medical school. So I will say part of what this fee schedule does, in a sense, is trying to correct for that demand-supply mismatch. The underpayment of primary care and behavioral health and the reduction of medical students deciding that they want to go into a residency in primary care and behavioral health as a result of that undercompensation. It's a result of this really flawed way of kind of setting the prices historically. And even digging one step deeper and tying in what I was talking about earlier, part of how they set the prices is in the intensity of the service and the physician time. And so the way that they've historically gotten that data is by the American Medical Association bringing together specialists, sending out a survey and saying, how much time do you spend on this procedure? How intense was it? And so the response rates of those surveys are actually in the single digits. They're really small. And it kind of starts to beg the question, who's responding to these surveys? Don't they know that it's actually helping to set their payment rates? So leading to all this bias and kind of entrenchment of the system as it has existed historically. And so part of what CMS said here is we've recognized that this has led to historic challenges in the way that we set prices. And so we're actually going to use empiric data. We can see now from electronic medical records how long someone's taking to do a service. And so that will help to renormalize in some ways some of this demand supply mismatch. But to your point, there could be future reforms that actually have Medicare more purposefully pay more for services that people need more of in order to drive more folks to go into those professions and more more folks to get access to those services. And there need to be changes on co-payment too. It's very complicated, but yeah, it's one of the fundamental areas that I think could use reform. One other point, and then we can feel free to ask more questions. You mentioned the other more private insurances and the differences between what they pay and what Medicare pays. A lot of third-party insurers they still usually base their prices as a percentage of Medicare. So they might say we're paying 120% or 200%. And so when Medicare goes up or changes, a lot of the other commercial payers do the same. And so there's these downstream impacts of the fee schedule as well that extend really beyond Medicare too.
Look, it has a huge impact because there's so many Medicare enrollees, but it also has that indirect impact on everything because everyone pays attention to Medicare rates. Question I'm asking is if that gap widens. I'm seeing hospitals, commercial insurance are paying hospitals 200 to 300% of Medicare on average. Physician services, commercial payers, 125 to 200% of Medicare. If that gap is widening, then the relevance, the importance of Medicare weakens. And to some extent, we lose this historical anchor that guides pricing very well and is somewhat deflationary because Medicare has had to be extremely careful and conscious of its budget. It can't just increase premiums every year the way that commercial insurers do and shift the burden of inflation onto employers. It's living under this budget neutral constraint. So it offers tremendous value as long as it, to some extent, is perceived as correct on pricing. And if it creates all these pockets of mismatch between supply and demand, and now commercial insurance have to substitute for that, and they do it effectively, then to some extent, Medicare might lose some of its potency, some of its leadership influence. That would be, I think, unfortunate. I'm a big proponent of Medicare drug negotiations, right? Because that's an example of us relying on the commercial space to do everyone's work for them. Medicare wasn't allowed to negotiate drugs, and I think we suffered. So that's a perfect example of, hey, Medicare does a great job. Where it's allowed to participate and influence and guide, we can retain some kind of control over inflation in healthcare. Where it doesn't exist, we seem to struggle. So it's just a very interesting topic. Let's move on to primary care. Primary care vis-a-vis this physician fee schedule. You've spent time on reimbursements into the primary care space. You've spent time on value-based care. You've worked a lot on quality measures across Medicare that I know that primary care is heavily influenced by. What are you seeing in this fee schedule that you like, dislike from the perspective of the primary care space?
Yeah, thanks for the question. Um, there's a few areas. There's the efficiency adjustment I mentioned earlier should bump up payments to primary care overall. But there's also this increasing recognition of um, uh, what's called advanced primary care and the need to pay for it. So this fee schedule grows on what the previous administration did in the creation of new advanced primary care management payments. APCM is the abbreviation. There's abbreviation for everything in government. That's one of them. And it's recognizing the time and the resources spent to really have those advanced primary care teams that have a way to do patient portal messaging back and forth with patients to make sure that there's a team there that's multidisciplinary that can take care of you, that has a care plan that follows along with your chronic conditions. And it's the kinds of care that, frankly, a lot of primary care practices are already providing around the country today. And so what this rule did is it also built on that and said, if you're one of these practices providing advanced primary care, billing for these advanced primary care management payments, we'll also pay for the behavioral health integration codes. So basically, if you're having a behavioral health clinician there and providing behavioral health services in the context of advanced primary care, it's going to be even easier to bill. Those practitioners don't need to take stock of every single minute of every day they spend doing the procedures, the integration services, but they can actually just bill it regularly for per patient per month basis. And so that's really important. There's also requests for information about chronic disease management and prevention, which are high priorities for this administration. And a lot of those questions have relevance for primary care practitioners. And whether that's how we better kind of capture the value, or should we pay for new types of services like health coaching or medically tailored meals? Those types of questions are there too. And so I can speak a little bit separately about the Medicare Shared Savings Program, the largest accountable care organization program in the country. There's
That's
some
going
change.
through a lot of reform right now,
Yeah.
and to the detriment, to the chagrin of some of the larger managed care groups that have relied on very nice incentives, reimbursements surrounding that program over the last 5 to 10 years. So a lot of repricing of large groups.
So for the Medicare Shared Savings Program, you just a quick background for some of your listeners. I imagine a lot of them probably know about this program too. So, but the largest accountable care program in the country, more than 11 million beneficiaries attributed, and there's I think a recognition in the fee schedule also of the importance of driving value through participation and driving savings here. And so they basically said that you can stay in an upside only model for 5 years. In the last administration, it was 7 years. They're proposing to shorten that to 5 to push people more towards downside risk. I will say most ACOs are already in both upside and downside risk models. And so that's like fundamentally different from the first Trump administration when that was less the case. But there's also questions about, we've seen actually that primary care practitioners, when they participate in an ACO, it's those ACOs that have 75% or more primary care providers, they actually have savings rates that are twice as much as ACOs with less that. And so there's a recognition of that in this fee schedule too, and asking questions about how do we actually drive participation by primary care providers in ACOs.
How do we drive consolidation?
Well, they're
I don't know
different.
that we need thousands of ACOs. If the benefits are really there through scale, which I can believe because there's plenty of infrastructure investment required.
We've actually seen that the smaller ACOs over time, community-based ACOs, physician-led, in many ways, they're actually saving more than some of those large health system ACOs that you might think would be bigger and kind of driving consolidation. So I would say that there's actually a lot of ACO policies that are anti-consolidation because they're specifically for the small ACOs.
How do they drive that extra savings with less dollar investment in analytics, physician engagement, patient engagement, education, training, compliance, right? Don't all those requirements, those operational needs, don't they require that high level of investment to be able to execute well?
Well, they actually oftentimes rely on like third-party conveners that are experienced at getting ACOs together to provide a lot of those functions.
Okay, so the outsourcing.
Yeah. And on the health system side, when they're these really large ACOs, it's been a little bit harder historically because the health system ethos over time has been heads in beds in a fee-for-service architecture. And so when you think of an ACO and you're now constrained in the total cost of care, you actually save more if there aren't necessarily heads in beds all the time, then that's a total frame
Sure.
shift for health systems.
Misaligned incentives.
Yeah. And so if you have those incentives on the Medicare side, but not necessarily other payers, there can be challenges from the health system perspective that maybe small physician-led ACOs don't necessarily face.
So the fee schedule that just came out, does that also cover whatever incentive programs exist under Medicare Shared Savings, or that's a totally separate timeline and update? Any changes in risk stratification requirements and star ratings, it's totally independent of what just came out.
So it's the Medicare Shared Savings Program updates actually occur in the fee schedule. So
Okay.
of the 1,800 pages, there's a couple hundred of them devoted to the Medicare Shared Savings Program.
So did you have enough time to look at, I mean, this is a lot to cover.
Yeah.
What change, I mean, I'm thrilled that we get to ask you this. What changes occurred there that you think really stand out?
Yeah, I would probably characterize them as more minor changes this year. And I'm not totally surprised with that. It oftentimes takes a little bit of time for an administration to like fully figure out the direction of the Medicare Shared Savings Program. But it's that increased or decreased amount of time before ACOs have to move to two-sided risk. There was some allowances for smaller ACOs by changing some of the definitions there that basically you have to get above 5,000 enrollees in the ACO, and the way that we calculate it made it more flexible.
Wow. Okay.
So
more welcoming.
yeah, there's probably some smaller changes. And I think that also, I wouldn't be surprised if we're kind of waiting for next year's rulemaking on the Medicare Shared Savings Program to get a fuller picture on the direction. But some of what I mentioned earlier, questions about participation of primary care providers in ACOs, gives a little bit of a directional indication as well of, I think, some of the focus here too.
Okay. So the quality strategy in Medicare, the national quality strategy in Medicare that you were part of, and the universal foundation of quality measures, what were some of the big lessons that you took away from that experience?
Yeah. So I think it's really important that all of the different centers at CMS work together collaboratively on a quality strategy. And so this was the national quality strategy and the universal foundation of measures. You can think as a primary care doc myself, when I see patients in my office, if each individual patient has a different payer and they're all focused on different quality measures, then that can be really challenging to know what quality measures to focus on to really both improve quality of care, but also enhance the financial return based on the metrics. And so this was all the CMS centers getting together and saying, we are going to use the exact same quality measures wherever we can and it makes sense. And so that universal foundation actually had a focus on chronic disease and has a focus on chronic disease and prevention, which is still a priority of this administration. And the fact that it's the same across the board, that can really reduce burden for providers too, for the reasons I mentioned. And that's also a focus of this administration. And so, I mean, the quality measures over time may evolve with the differences in focus. However, the process of all the centers getting together, coming up with a quality strategy, and figuring out how to move forward can just mean really important changes for individual clinicians. And then we can also compare across programs too to see how each one is doing.
Do you have an anecdotal best example of a quality measure that we've started to track in the last 5 to 10 years that has made a difference? Like has really shone a light on a practice, a way of delivering care that we've all reacted to as a result, that we overlooked, say, 15 years ago? What would be an example of significant material progress in quality measurement on a national scale?
It's a great question. I think it sounds kind of simplistic, but just like the blood pressure measure and making sure that people are paying attention to people's blood pressure and getting it below a certain amount is.
I'm feeling the primary care physician in you come out right now.
Well, so I will say that
I've got my sleeve up ready for you.
There was a model actually in the Innovation Center that tested this. Like if we're actually paying attention to patients' cardiovascular risk and doing things like reducing blood pressure and making sure that patients take their statin, lower their cholesterol, what's the impact? And it actually found that we lower mortality, we improve mortality when we do these things, which is, and just by virtue of having the quality measure in place that is doing these things, they saw an improvement in mortality. And so CMS has kind of focused on blood pressure management as part of the Universal Foundation. It's part of the reasons it's there, but it reduces heart attacks, it reduces strokes, it reduces deaths. And so it's just really important, and kind of focusing on the fundamentals of medicine. And it might seem like a simple measure, but getting a patient to take a blood pressure medication, you got to know about that person's life, what they value, what their daily routine is. It can be pretty complicated. And so making sure that that is valued by our healthcare system can really drive towards progress.
Are we in a healthcare revolution? Whether it's wearable devices that are moments away from being adopted broadly, whether it's sharing personal healthcare data in a way that we can individually benefit from as patients, real time, obviously artificial intelligence, and all the ramifications of artificial intelligence, whether it's orders of magnitude improvement in clinical research or actual delivery of care, or is it still somewhat out there in the periphery and basically a big maybe?
I'm probably lean slightly more towards the latter, but I think it's an exciting time. There's certainly lots of changes going on with AI and the new technological changes that affords both clinicians, patients, and large-scale healthcare systems.
Why do you remain a little bit skeptical, Douglas?
And that's the corollary.
What are
I
you
think
seeing out there that the average journalist has missed?
Well, I think that there's just some fundamentals of the US healthcare system that are profoundly important. And if you have people that don't have access to healthcare, that don't have access to Medicaid, that can't see their provider, like all of that data is not going to be put to use. And it doesn't fundamentally change the fact that we pay way more than other countries for similar services, whether that's for drugs or surgeries or whatever it is. And so the fundamentals of the US healthcare system haven't necessarily changed by virtue of new technological improvements. And I worry that a lot of the most underserved populations too will find it the hardest to access some of these new technological advancements. Maybe it's not in their language. Maybe they speak Spanish. Maybe they in their family are older and aren't as fundamentally used to interacting with technology in the ways that younger generations are. I think that also a lot of the AI revolution is built on pre-existing data, and oftentimes that pre-existing data, we know that it can be biased because people have biases. And so AI can without proper management, bake in a lot of those biases. And so
the fear of a two-class health system made worse, not necessarily made better. The gap between high-income life expectancy and low-income life expectancy widens, doesn't shrink. So we're not necessarily out of the woods on all of this for a whole host of reasons, especially with Medicaid shrinking, Medicare reimbursements, the gap widening between what they offer and what commercial payers offer, and technology companies needing to report to their investor base that they're generating wonderful returns. So who's paying for all that technology? So I think you make a great point that it's easy to get excited, but we've got 30, 40, 50% of the populace, depending on which state, that isn't necessarily getting the best care today nor tomorrow.
Yeah, it's unfortunate, but true.
So your experience in Pennsylvania, working for the Department of Health there, things that I would note about Pennsylvania, a lot of hospital usage, 30+% greater inpatient days per 1,000 population, lots of emergency room visits relative to the rest of the country, higher usage, lots of hospital admission, lots of hospital beds. I'm looking at the, it sort of feels a little bit more like New York, a blue state, in that the percentage of uninsured is actually quite low relative to the rest of the country. If 9.5% has been the norm, I know it's going to change now. Pennsylvania is at 6.6% uninsured, so it sort of brings it closer to Massachusetts and New York than a place like Texas. So a real commitment to provide care to as many people as possible, but maybe an over-reliance on hospitals to deliver that care. And that's not necessarily a criticism, because I think for a large segment of our population, they're not necessarily individually building a network of primary care physicians and outpatient specialists to take care of their every need. They're going to the emergency room because something's wrong. So easier said than done. And if they're chronically unwell, things can get really wrong really quickly, which again speaks to acute care in hospital settings. So what I know you were there during COVID, which is an altogether separate topic, more controversial topic, I think, still. What were your key lessons that you took away from your time in Pennsylvania? And how do you frame Pennsylvania relative to the rest of the country in your own mind?
Pennsylvania is a really interesting state. Areas of very high urban density, areas of very that are very rural in nature. There are profound disparities across the state too. If you're born in certain census block groups in certain neighborhoods in northern Philadelphia, for example, your life expectancy might be as low as 62, 63. You go just a mile to the south, your life expectancy could go up to 84, 85.
Isn't that amazing? 1 mile, 20 plus years of life expectancy.
And if you go back to historical redlined maps and the New Deal era, a lot of the same areas that were historically redlined are the same areas that are struggling with current health disparities, poor outcomes, lack of access to healthcare. But it's also fundamentally wrapped into the social determinants of health, lack of access to food and stable housing, transportation. And so when you cite the statistic about having high ED and inpatient usage, part of it can be related to that. And the other aspect is that Pennsylvania tends to be a little bit of an older state. There's a lot of retirement communities within Pennsylvania as well. And so on the Medicare side is very heavily managed care. There's many states that have like a managed Medicaid. And in Pennsylvania, there's not only managed physical health MCOs, but there's managed behavioral health MCOs. There's managed long-term services and supports MCOs. And there's also there's CHIP MCOs, the Children's Health Insurance Program. And so there's a lot of
lots of dollar spend controls, which actually translates to pretty low spend per capita.
Yeah.
So despite all that coverage and all that hospital usage, per capita spending not out of control relative to the rest of the country.
And they do a really effective job.
Give you an example. Oregon spends more per capita than, let me look at Pennsylvania. Hold on.
Yeah.
Let me make sure I get my numbers right. Yeah, there we are. Pennsylvania. Very low spend. $8,700 per capita on healthcare spend in Pennsylvania, according to the Kaiser Foundation. California, 10,500, Oregon, 12. The national average is the same as Pennsylvania, 8,500. So it does suggest a lot of managed care. So controls over quantity and pricing.
Well, and so another piece of that, though, is just I have to give kudos to my former colleagues at the Pennsylvania Department of Human Services. Because there's so many different managed care programs, they are really highly effective at overseeing MCOs using the Medicaid negotiation leverage where they could to reduce prices in pharmaceuticals, for example, really trying to make sure that they oversaw use of prior authorization so that it's consistent and done in an appropriate way. There's a lot that the Pennsylvania Department of Human Services does because they've done managed care so well over the years and have really been working with their MCOs to provide the highest quality care possible too. There are regular meetings with each of the MCOs where the medical directors go over like all of their outputs on all of the quality measures and said, we noticed that your blood screening of children has decreased. Like, what are you doing to fix that? And then they'll follow up the next month and just make sure that what the MCO said is going to happen is actually happening. And so there's some, I think, real good lessons to be learned from Pennsylvania there for other states that are interested in thinking about their
I'm going to
managed care.
test you. Who's the lowest spender on healthcare per capita in this country?
Well, so that's not necessarily the best indicator of like a good healthcare system because it could be that the patients aren't getting access to a lot, and that's why.
It could mean that.
I don't actually.
It's going to shock you. They're in at $5,000 per capita when the average across the country is 8,500. Florida.
Yeah. Well, there's also a lot of folks that unfortunately don't have access to a lot there too right now. So, yeah, they are interesting statistics, but it's important to take it in the larger scheme of everything else as well too.
Douglas, I want to thank you for your time today. I learned a lot. It was a great interview, and I hope that we can have a few more together. I do have something planned for the CMS the ex-CMS team. We're going to get you all together and maybe have a group chat as well. But I really appreciate your time.
Perfect. Thank you so much. It's great being on.
Thank you.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.